Being here today. Really appreciate your time. We've got a great presentation for you. Before we get started, I will share a reflection, and this is a special reflection today. Over the holidays, you may have seen some communication, probably on social media. A very positive message began to spread across the nation. It was a message of respect, of support, and encouragement, really, for our nation's nearly 800,000 law enforcement officers. They've had some pretty bad press lately. If you've been paying attention at all, I'm sure you've seen some of that. But today is actually National Law Enforcement Appreciation Day, and communities across the nation are encouraged to take this opportunity to share the message with law enforcement officers, with their families. Let them know that we appreciate their commitment to their service, the sacrifices that they make, and we support them. So the reflection that I'm going to share is in that light. This is called the person behind the star. It takes a special kind of person to wear a star and a gun, to devote their life entirely to fight the battles that must be won. So often they're not appreciated for the job they've sworn to do, but they gladly lay down their lives because they wear that star for you. Some seem to think that they really have it made, that all they do is ride around for the salary that they're paid. But every time trouble appears, they are the first to get the call. It's only then we realize they're special after all. There's a person behind that star who has feelings just like you, so seldom do they get the praise for all the things they'll do. If you ever stop to think of what they face day and night, you'd respect what they stand for and learn to treat them right. There's a person behind that star who's not made of steel, and the things we watch on TV, to them, are very real. They have families of their own, they can laugh and they can cry. Each day they put on that star, this could be their day to die. They chose to uphold the law, a decision made from the heart, to protect us with their lives and give each child a better start. To try always to remember there's a person behind the star, and they'll help you be the first no matter who you are. You should say a prayer each night to thank God that they're there. When you see them on the streets, you should show them that you care. Without the sacrifice they make, we'd always live in fear. They should be commended to wear the star they hold so dear. They've never turned their back on you, faced danger close and far. All Americans should salute the men and women behind the star. So something to keep in mind as you go forward, and next time you run into an officer, don't hesitate to thank them for the work that they do for us. So we do have associates with us in Waupun and Ripon. Looks like we're dark out there, but it looks like I think they're connected, right, Katie?
Mm-hmm. You're good.
There are a few things on your table. We have information about February's session. It should be a great session about perinatology and neonatal intensive care services here at Agnesian HealthCare. That is on Friday, February 13th. You'll see the familiar yellow sheet. You know I take your comments very seriously, so please continue to provide feedback. I really do take that to heart, and we make changes based on what you say. And if you're interested in winning or a chance to win our Agnesian HealthCare bag and getting credit for being here, please fill out the green slip. And finally, Terry has asked me to just make mention, we have a Healing Through Art program that we've started, I don't know how long ago, a few months ago? September. It's been very successful so far, and we have a session starting on Monday. In order for that session to continue, though, we do need one more person. So if it's something that you or someone that you know or care about may be interested in or benefit from, just talk to Terry in Journeys. I think it's a great program, and whoever it is will benefit from being in it. So, without further ado, I would like to introduce Dr. Figueroa Castro. Dr. Figueroa Castro is an assistant professor of infectious diseases at the Medical College of Wisconsin. He's also a physician here at Agnesian HealthCare. We're very fortunate to have him. He's done his residency in internal medicine at the Medical College of Wisconsin and a fellowship in infectious diseases. And he has got a great presentation and will be well informed once he's done. So, without anything further, thank you.
Can you hear me okay? Yep, okay. All right, well, thanks for coming. I guess you got lucky because, or maybe unlucky, I guess. The first thing in the morning was a little bit late. I always messed up the timing that takes for my driveway to be clean. So I guess one of the advantages is that the first couple of slides, excellent pronunciation from Nicole. So some plus there, some gain. Okay, so basically this talk is going to be one explaining very generally what infectious diseases is as a discipline. Number two, trying to justify my existence, I guess, as an infectious disease specialist, what I do, what I am doing this in first place. And three, maybe showing a couple of cases that I have seen here in the hospital, very throughout. I mean, I guess in a way not very complicated, but just to give you an idea of the things that I've seen here. So this is happening already in your backyard. So what are infectious diseases? Infectious diseases are the clinical manifestation or the disorder caused by microorganisms, which can vary from viruses, bacteria, fungi, parasites, or prions, which is a very special kind of infectious agent. Very rare, but you probably have heard things like Creutzfeldt-Jakob's disease or familiar fatal insomnia, things like that. So very, very uncommon. But by far, bacteria, viruses, fungi, probably more closest to our experience. First thing is that we carry a lot of those things in our bodies pretty much all times in different places. Earlobes, throat, skin, gut, genital region, and by far they don't cause any problem. And data that we have collected throughout the years suggests that actually they share some special things and they do some work for us to try to keep us healthy. Some bacteria, for example, in the gut are very important in promoting the immune system response, and at the same time, they actually help us in absorbing some of our nutrients as well. So that just tells you that we, as a species, have learned how to live with other animals that have been in this planet for much more longer than us. So again, they're usually harmless, but sometimes things go wrong either because you get something that it's intrinsically designed to cause problems, or something that doesn't cause problems if they're in the right place, but when they get in the wrong place or they happen to be in the wrong person, that's when things start going wrong. So as a discipline is again not necessarily the newest thing on the block, but I think in comparing with other disciplines in medicine, I think it's a relatively new thing. If you think that at least less than until 1700s, 1800s, this was one of the predominant theories for diseases, which was the miasma theory, just bad airs in the air transmitting somehow diseases. And it took a while before the germ theory of disease, explaining infectious diseases and proving that these organelles, these little things, cause disease, and really had a big impact in the practice of medicine. But even in our days, if we think about some common diseases, that tells you that those influences from before they still exist. So the language kind of carries on in a way. So you think, for example, in malaria, that's malair, bad air. You think about cholera, so that gives you the ideas of how people used to explain diseases based on the four humors of the body, whether a person was choleric or bilious and whatnot. Or things like influenza, which is basically an effect from the stars, thinking that instead of these organisms, spirits or different gods or things that were happening in the stars were explaining why we were getting sick in the first place. But the germ theory of disease is definitely carried by three of these gentlemen, Louis Pasteur, Robert Koch, and Joseph Lister. There were some other people involved in the development of the germ disease, but these three masters basically gave all the background, all the basis for what infectious diseases is, starting with Pasteur working on rabies and trying to prove that there is an explanation, microorganism causing disease and not by miasmas or by spontaneous generation, which was another part of the theory. Robert Koch, which is pretty famous for proving beyond any doubt that tuberculosis, mycobacterial tuberculosis, was the cause of tuberculosis, and the way he proved that disease is actually very commonly used to prove that an infection is caused by a particular organism, and those are the Koch criteria or Koch postulates. Joseph Lister, not necessarily a microbiologist per se, but he put a lot of things together and saying, infectious diseases, microorganisms, maybe this is why people in surgery are having some problems with infections after having those procedures. And he was the first person that started introducing strict antisepsis in a surgical setting, so kind of building on what the germ theory of disease was. There were some other people that are important for infectious diseases. John Snow, which described it and controlled the cholera outbreak in London in 1848, even without the knowledge of the existence of microorganisms necessarily, but just based on good epidemiological insight, measuring things, comparing things, and just good analysis. Or the history of Hickman Semmelweis that we all hear about when we're talking about hand hygiene, that also suggested that hand hygiene is very important, and unfortunately he got the price of being put in an asylum and dying from the same disease that he actually tried to control by just hand washing. So I deal with a lot of animals, not strictly animals in a more strict sense, but I definitely deal with from very small things like these little things, which is an HIV virus coming out from a CD4T lymphocyte. I don't think I mentioned that this morning, but those colors are false, so it's not like the virus is green or things like that. Okay, so just wanted to make sure. And I deal with other things like Staphylococcus aureus, which is a very common malady in the hospital, outside, inside, so you name it. Or things like this, which is mold. This is Aspergillus, and again, there's a sample here of the size that we're talking about here, just to keep things in perspective. And this is just one of the multiple fungal species that are out there. And things a little bit bigger than that, and this is actually Giardia lamblia, so that causes giardiasis, very common parasite. And as you can see here, got a bunch of friends right here, and they are attaching and leaving some poke marks and polka dot marks, I guess, on the epithelium of the inner lining of the gut. So it's just like leaving scars. They just kind of attach, and when they attach and they produce these damages, that's when patients end up with a nice diarrhea from that. So that's pretty much the background for an infectious disease. You have something causing disease in a person that might or might not be necessarily susceptible. And also there might be the circumstances on how you acquire this bug in first place. So you can maybe pass it person to person, handshaking, kissing, having sex, or bites from insects or bites from animals, rabies, malaria, dengue, you name it. Ingestion of contaminated food or water, or exposure in the environment. So many different ways that you can get an infection, unfortunately. So it's just one of those pleasures of staying alive. You can get an infection. And because we're dealing with so many things at the same time, there are a myriad of manifestations. Just a couple of things to mention. This is chickenpox, which is a viral infection. It's kind of an interesting case because they thought he actually had smallpox, which is another viral infection, but which was eradicated with successful vaccination and public health measures. Or things like probably more common to our daily practice, a nasty boil, which probably has a Staph aureus, probably MRSA, which is probably ready to be either squeezed by the patient or squeezed by you, or lancet, you name it, and may or may not require antibiotic treatment. Or some other things like pneumonia, which can be caused by a myriad of organisms. In this case, this is interstitial pneumonia right here and here, and this is caused by Pneumocystis jirovecii, which is a common ailment in patients who have advanced HIV infection or people who have had bad organ transplantation or treatment for cancer. And again, gives you an idea how these things can be in the wrong place or in the wrong person. It's very uncommon to see a normal host to have Pneumocystis jirovecii pneumonia. But if you go back in history to places, for example, who had problems with severe starvation, the greatest example, the Battle of Stalingrad in World War II, a lot of people die from just not having enough to eat, and many of those patients end up being really starving to death. And those patients end up with Pneumocystis pneumonia, actually. So it's not necessarily that you have to be not healthy to maybe be unlucky enough to get one of these infections in the wrong circumstances. So again, depending on the kind of organism, symptoms and signs can differ, and there's a myriad of things that can happen, head to toe, you name it. By far, fever, fatigue are probably the most commons, but as I will tell later on, fever unfortunately can be caused by other things like infection. It's probably one of the things that I see more often as a reason of a consult. Some of them can be prevented by vaccines, despite of what you hear on the internet, and frequent hand washing is still recommended. So if you put things in perspective, nowadays infectious diseases are probably not the first killer worldwide by far. The most common causes nowadays are ischemic heart disease and stroke. And you can see other diseases like COPD, road injuries, and hypertension. But still, there is a specific number of diseases from infections that can still cause significant mortality. I can probably make an argument that maybe these patients end up maybe getting a bad heart attack, maybe because they were dealing with an infection in the first place, something that just puts some extra pressure on them. But still, you see kind of the common killers still, so pneumonias, bronchitis, HIV, diarrheal diseases, diabetes. You don't see tuberculosis no more as a cause, but it's still important in some other places. So maybe in places with a low income where infectious diseases might be more of a problem. And actually that was my situation where I decided to be an infectious disease physician in the first place, because that's what I saw during my initial training. So still, pneumonias, HIV, malaria, tuberculosis, but as you can see also kind of creeping up some of those chronic diseases as well. And kind of the similar story for the United States. Again, chronic diseases, tobacco, obesity, still kind of the main killers, but it's still, you still have some room for some infections causing problems, influenza, pneumonia. And again, you can make an argument that maybe some of those deaths from cancer, heart disease, and COPD could be related to a bad infection that happens when they were receiving treatment or as a potential predisposing factor. So, still important. And what makes my work really nice, if you can put it that way, is that I never get bored. I always get really good stuff to read and new stuff to learn and new stuff that just keeps on cropping and popping everywhere. So at least in the last 25, 50 years, we have been dealing with some of those infections that we don't know about before. HIV/AIDS, first case description in 1981, but probably arriving in Africa probably in the 1920s, 1930s. The scare of SARS-CoV in 2003, the current ongoing Middle East respiratory syndrome, coronavirus infection in Middle East, the Ebola virus disease that we don't want to talk about no more, Nipah virus, hantavirus on the west part of the country, West Nile virus infection, Legionnaires disease in 1976, and probably something more common to our daily work, this epidemic strain of Clostridium difficile, which causes diarrhea, but unfortunately that toxin that causes diarrhea is just in a turn-on mode all the time. So that's why it's so nasty. Or some kind of more funny things like monkeypox or Cryptococcus gattii, which is a fungal infection that is more common in the Pacific Coast, Oregon, Washington State, Lyme disease coming from Connecticut, and things that probably we're doing ourselves by not taking care of when to use and more especially when not to use an antibiotic, like community acquired MRSA, extremely resistant tuberculosis, and a gamut of gram-negative rho infections like KPC, Klebsiella pneumoniae carbapenemase, and the M1, which came from India, and other carbapenemase-resistant Enterobacteriaceae, just to name a few. So what do I do? So just try to justify my existence, although I think I made a good point. I'm a doctor. I'm an infectious disease physician, but before that I did some training in internal medicine, like you heard at the beginning. And pediatrics can do that as well. They can have some additional training in infectious diseases, and it can be 2 or 3 years of training in infectious diseases. Some people do an extra training on adding general clinical, translational, or basic research, or some combined programs so that have public health as well. So that's where I come from. So what did I learn on the fellowship, and by any means I didn't learn everything during those 2 years. I'm still learning. We go through the gamut of all these organisms, and again, during the time that I trained as an infectious disease physician, I'm sure that there were some other new infections that I didn't know about. But there is a common background or some common knowledge core that I needed to acquire during training. And probably one of the most common ones will include things like the use of antibiotics and the effects that might have, the side effects, when to use it, and actually more to being an advocate when not to use them and when to use them properly. I got some additional training in immunology, not like an allergic immunologist specialist, but some background that tells me when an infection might be a presentation for a person that might have a primary immune deficiency, or thinking about people who are more susceptible to certain kinds of infections. So, for example, the person that has lost the spleen for car accident, or because they needed treatment for things like immunothrombocytopenic purpura, those patients are going to be at risk of having a very particular kinds of infections with something that we call encapsulated organisms, which are bacteria that have kind of a sugar coat, so kind of an M&M basically. And the body's unable to recognize those bugs as usual without the assistance of the spleen. The spleen generates some proteins like topsin and some other things that tell the body, hey, something wrong is going on, you need to go there and attack it. So we have also some additional training on epidemiology, so basically the idea of how infections spread, make sure that we know what the agent is, the environment, and the host, so kind of the classic trial for epidemiology. And also that comes with infection control, which is also actually a thing that I do as a secondary post in St. Joseph Hospital in West Benson, the chief of infection control. And so again, I'm never bored, basically. But I don't do this alone. I have some extra work. Definitely the people that I talk to them the most will be the guys from the laboratory and pharmacy and infection control. And so the first thing, they're very helpful, especially when you call them. So I don't know if you noticed, but 10, 20 years ago, people used to go to the lab and talk to the techs and things like that. Nowadays, well, it's not on the screen, so therefore it doesn't exist. It's always good to talk to people. And I have to say that because my wife works in the laboratory, so now you can say that I put a good word. So the laboratory is very helpful. So this tech, for example, is working with an agar plate. So it's just a plate which has some culture media. It's just kind of a gelatin right there. It's just kind of a free buffet for bacteria. And the tech is just using this device here to isolate some of these colonies, which are aggregates of bacteria growing in this plate. So there are different kinds of media, different kinds of bacteria like some things, they don't like others. Some of them are very picky, just like kids. So you have to give them some nutrients. So in this case, for example, this is a conky agar, and this is for gram-negative organisms, and I think this is Klebsiella pneumoniae. I think the tech is actually more work ahead. You see the other plates here waiting to be read. And some organisms, again, depending on what you want to isolate in the laboratory, they will do some other things for you. And again, that's kind of where it's helpful to let them know what you're thinking about, so they can say, maybe we need to use this different plate. So for example, this plate, this is the kind of the original medium they have, this kind of reddish here. And the lab tech will kind of streak the surface with maybe a positive culture, and they will leave it grow in an incubator under certain conditions. And the bacteria is causing this change in the color in the medium. So in this case, it's MRSA. Generally speaking, the letters don't come in the result. So the text will need to know what kind of colonies they have, if the color, and they will do some other things like gram stain. So they will take a look at under the microscope, and that might be helpful, as we can see, as you will see in one of those cases. I put this one not because they will do it for me in the laboratory, because this is an electron microscopy picture, but this is a Staph aureus. And maybe one of the things that I want to show is what a Staph aureus can do, which is kind of causing this slime, creating this slime all over, and you see bacteria kind of living in within that slime. And that's why Staph aureus can be kind of difficult to kill in first place. You can imagine that this biofilm or this slime in things like a pacemaker wire or a joint replacement or some other kind of prosthetic material like a valve, killing those bacteria can be pretty bad. Antibiotics don't really penetrate that good into these things. So, and unfortunately, no other bacteria besides Staph aureus can cause these problems. So those are the kinds of things that I also think about when I recommend either using this antibiotic or not, maybe not in a second antibiotic. Again, this is another sample of what the lab will do for me. So they will streak the whole agar plate with bacteria, and then after they let them grow, they just drop some discs with a very specific amount of antibiotic. This has erythromycin, this has tetracycline, and as you can see, these bacteria kind of growing freely here, all happy. Here around this antibiotic, nothing is growing, so that tells you that the antibiotic is working, and that's how the laboratory will let me know whether an antibiotic is okay or not. This is kind of old school, actually. We now have automated machines and cartridges. They will do pretty much the same, but this is what we used to do before. The one on the left is kind of similar, but I don't know if you can see on the picture. The strip here has some numbers, and the numbers are kind of going up as you go on top. So you got like 0 point something, and then 3, 4, and then this one is 256. So it's pretty much similar to what the disc is, but the concentration of the medication is changing. So very small concentration, getting bigger, getting bigger, getting bigger, a lot of concentration right here. And I don't know if the picture is clear enough, but it looks like a teardrop around the strip, right? So that tells you that here in this area it's not growing, but here with less concentration it's kind of getting closer to the strip until to a point that it just doesn't matter if the strip is there, they will just keep growing. So the place where it's kind of touching here, the teardrop at this level, they will give you a number. And this number will tell me the minimal inhibitory concentration, so the amount of medication needed to stop the multiplication of this bug. And based on some studies that we have done, not here, but all over the place, and we have some standards for that, then the laboratory will tell me whether this is susceptible, intermediate, or resistant to the antibiotic. So, although I love that you can send me more work to justify my existence, I'm pretty sure that your primary care physician can take care of a lot of infections out for you. I'm sure that I'm not going to see a lot of patients with common colds, but your primary care physician might end up requesting an infectious disease specialist visit. Don't get scared. If maybe you have an infection that has been difficult to diagnose, things like having fever, fatigues, this and that, but we haven't really been able to pinpoint what's going on, or fever of unknown origin. That's a very common cause of an infectious disease consultation. And unfortunately or fortunately, those things can be infections, those can be some other things. They can be cancer, inflammatory conditions, you name it. Maybe a high fever and things maybe are not getting really better. Or you throw the usual antibiotics that most of them just kind of work, but this time maybe it's not working, or the cellulitis that just keeps on coming back for whatever reason. I don't know what's going on. Or maybe in a person that you know that they might have a higher risk of having an infection. So for example, a traveler that is going overseas, or a person who is having a cancer treatment that is going to get low counts, they're going to be neutropenic, higher risk of infections, or a person that is going to have an organ transplantation, so they're going to require some specific care from infectious diseases sample. This one thing I talk about, one case I have for overseas travel. I have a person, Amish person, got shunned, never received vaccines, and then he showed up in my office asking me for vaccination or recommendations because he got a girlfriend in the Philippines and he was ready to go to Manila to get married. So we have to start from scratch. I'm sure that person probably a high risk for having infections and some other things. Or maybe the last thing that to justify my existence is that some conditions are probably more on the realm from infectious diseases like HIV infection. But nowadays, maybe some primary care physicians may feel more comfortable doing HIV now that we have really great medications to treat them. So things to think about. So I'm going to present a couple of cases, nothing very complicated, but those are cases that I've seen here. So those are real cases to try to show what I do for the patients here. So the case one is a person that has a history of end-stage renal disease on dialysis, has liver disease from alcohol abuse, presented to the emergency room with fever, malaise. They took a look to the emergency room, nothing really major on the physical examination except for being hypotensive, and the lab were maybe some leukocytosis, so that sounds like an infection. In a person with end-stage and liver disease, they can get really sick really, really fast. So they put the patient on vancomycin and ceftriaxone, and they drew some blood cultures when he was in the emergency room. And in the first 24 hours, then the hospitalist was calling and saying, hey, Dr. X, you're having some positive blood cultures, but the first call that the person will receive is not to tell them, hey, you have Enterococcus faecalis on your blood. They will call you to say, hey, Dr. X, you have a positive blood culture for gram-positive cocci in chains. So what they did is to take a look under the microscope and take a look to the shape and tell you, hey, this looks like this, and then you have to say, that sounds maybe like a streptococcus, or maybe that sounds like Enterococcus, and then the laboratory will need to continue working that up until they can give you a name, and they can give you a susceptibility testing to tell you which antibiotics are going to be useful or not. And in this case, that was very run-of-the-mill E. faecalis. It was susceptible to ampicillin, penicillin, gentamicin, tauramycin, so relatively easy to treat with some caveats. However, when I saw him, I said, well, that's great, but I think we need to take a look to his heart, because he's a person with end-stage renal disease. He has a catheter. He had repeated use of the catheter. That's most likely how this infection takes place. The patient didn't have a lot of GI symptoms in the first place. So this is what it looks on the agar plate, so Enterococcus right there for you. And the patient required an echocardiogram to rule out endocarditis, which in this case was positive for a vegetation. And the patient required treatment for endocarditis. So it's not only thinking about, hey, he had positive blood cultures, hey, he was Enterococcus, hey, it was susceptible to X, Y, and Z, but thinking about how did this happen, where did this come from, what else are we thinking about? So at some point I feel like a Cassandra just asking for, think bad things are going to happen, but if you don't know what's going on, then maybe you treat only for 2 weeks and then it's going to come back with the same infection if you don't know about it. So that's kind of what my thought process the majority of the times really comes from. It's just kind of saying, where did this come from, how did this happen, what we need to look afterwards. So in this case, probably it will make a difference, because instead of treating this patient for 2 weeks with maybe just ampicillin, this patient required ampicillin and gentamicin for 6 weeks, with the complications that comes with antibiotics for that prolonged period of time. Renal toxicity, maybe hearing loss, bone marrow suppression, and those are the kinds of things that also I have the training for and I look for, and that's what we recommend to do some lab work once in a while when they're receiving the treatments. So again, endocarditis, an infection of the inner surface of the heart, which is called the endocardium. It affects heart valves, but it can also involve other areas inside the heart or things that are inside the heart, like artificial heart valves, pacemaker wires, implantable defibrillators. Not very common, but about 10 to 20,000 people get this infection. And if you happen to have endocarditis about a century ago, you'll be dead. That would have been basically fatal. Maybe kind of a slow process, but you would have been dead, basically. But even with antibiotic therapy nowadays, it can cause a lot of problems. You can imagine, for example, if this mass, this vegetation, this accumulation, this mixture of bacteria, leukocytes, fibrin, platelets, just dislodging from that vegetation, it can travel to other places and get you a nice stroke or give you an infarct on your spleen. And that causes inflammation, that can cause renal failure. The valve might be completely ruined. Patient might end up with valve replacement and heart failure. So it can be very nasty, even when you know what's happening, how to treat it, and whatnot. It's a serious infection. So this is not the patient, fortunately, but this is a PET specimen. And this is the ventricular area here. These are the atrium. This is the mitral valve. And these things here shouldn't be there. And those are the vegetations affecting how the valve works, and also with the risk for some other complications. So the The number 2 case is a person who I saw actually kind of late on his condition, but it was kind of an interesting case to go through. So he had a history of chronic lymphocytic leukemia. He was kind of at the end of his options, so he was receiving this treatment, ibrutinib. The fact that I can pronounce it doesn't mean that I know everything about that is to know about ibrutinib, but interestingly, it was part of what I had to learn when I had to manage this patient. We'll see that in a minute. So he was chopping some wood in his home, like as usual, and he developed a skin lesion on his scalp, and it's not sure if maybe he got a chip kind of pinching on his scalp somehow. The lesion then just got worse, very buggy, tender, red, painful. Went to urgent care, got some antibiotics, kind of got better, but then it got worse again. He started having some fever, some chills, so he decided to get admitted, put him on some antibiotics, still kind of having some problems. They called surgery, they did some debridement, and at that time, actually, when they called me with the result of the pathology, actually I was in Chicago, but I was able to tell them what to do, actually, just from the path. Although this is not the specimen from the patient, it's somewhat similar to what you see here. And I don't know if you can see this, but this looks like branches from a tree right here. So you kind of branch in here at an acute angle here. And you have another one here, and another one here, another one here, kind of plumpy here, but kind of more narrow here in this part. So this was actually cutaneous mucormycosis. So this was a bad fungal infection in the first place. And actually we isolated mucor from the surgical specimen actually. Although it can be caused by some other molds like Rhizopus, Coningamella, Saxina, and some others. So this is more likely to happen in people that have basically no immune system, the organ transplantation, the person that is having active cancer treatment. And it can have multiple presentations, so again, cutaneous, as we saw, but also can cause some more nastier disease like sinusitis. And when that happens, then we get worried that sinuses are so close to the cranial vault that I can go to the brain and cause a nice brain abscess. Those are pretty much fatal. Or it can cause infections in the lung as well. The interesting thing is that it can happen actually in people who have normal immune systems. And I don't know if you guys remember the tornado that happened in Joplin in Missouri, maybe like 3-4 years ago. Actually, my partner, I was working in Missouri, actually my partner wanted to go to the hospital, and the hospital actually got destroyed after the tornado. So there were a bunch of people that got up under the rubble and all the debris and mud, and apparently it took some time for them to get rescued, obviously, because of the extent of the damage. Some of those patients had these open wounds that got contaminated with organic materials, with mud, and they ended up having this cutaneous mucormycosis. So that tells you that it's not only whether they were having problems with the immune system or not, which probably they didn't have, but also what were the conditions in first place to put them at risk for having this kind of infection. So a couple of examples. This is sinusitis. Again, you see that it's kind of protruding, kind of pushing from behind, so the eye is kind of pushed out, and probably having a cranial nerve paralysis right there. Some nice proptosis. Kind of a more extreme examples, kind of pushing. You have some chemosis right there. And again, these are the ones that we get worried about because the sinuses are so close to the cranial vault that they can kind of invade and they can cause a brain abscess, and those are pretty much impossible to treat. So this is what I do. Again, I don't get bored at all. A lot of stuff to do. And I guess I mentioned this in the morning, but I guess working as an infectious disease physician really gives you a sense of humility. These bugs have been in this planet for millions of years, and they will be here even after we're gone. So I think it's important to embrace them at somehow. The last couple of years, we've been receiving a lot of information on how important it is to have bacteria on ourselves. So I guess you have to treat them nicely as well, and maybe another reason why try to stay away from antibiotics, just leaving them alone if you can. So we see patients here in the clinic. We have clinic every Tuesdays in the mornings. In the afternoons, I try to run on patients on the floor. my disclosure. I don't think that's enough for this institution, but what we can do, what we can. And those patients require referral from a primary care physician or a specialist. So we're not going to see patients just calling from because they got the phone number somehow. They won't get seen that way. So we see patients with HIV. So you have any patients that you don't feel comfortable dealing with that part of their care, they're more than welcome to be seen. And I'm open to some phone consultations and curbside consultations, or maybe giving some guidance until I had the chance to see the patients in consultation on Tuesdays if we can. So that's the story, and I'm sticking to it. Any questions? Yes?
Can we talk about prions just a bit?
Yeah.
The DNR seems to be so flippant in their attitude in regards to prions when it comes to chronic waste disease. When it comes to the crossover of animals to humans, how do you feel about that? Is there a strong correlation as far as you're concerned?
Yeah. Well, maybe we start with some background about what a prion is. So, prion is just kind of a word for a proteinaceous infectious particle. There were a couple of conditions like Kuru in Papua New Guinea, and Creutzfeldt-Jakob disease, and familiar fatal insomnia, scraping sheep, and mad cow disease in cows. That at the beginning wasn't necessarily clear what was the cause of those infections, but then there were some discoveries about these proteins causing disease. So what is the cool thing about that? I guess if you don't have it, it's cool, but the coolest thing is that it's an infection that is caused by protein, not by an organism. So if you go back to what an organism is, most of these organisms that we talk about, bacteria, fungi, parasites, they have DNA or RNA. So they have nucleic acids that tell them what to do and what not to do. Prions don't have that, so they just have protein. We think that the reason why that protein acts foolishly is the way the protein is folded. Instead of being folded as a nice alpha sheet, so it looks like a nice helix, it looks like a sheet of paper, so kind of a beta pleat conformation. So somehow this protein, abnormal protein, is able to contact normal protein because we produce that protein in its normal form. We have it in our genes. And then it starts a transformation between being a nice normal protein and becoming this abnormal protein. Now, the question is whether the protein, that prion is specific for any species. If you, for example, get exposed somehow to the prion that causes a scrapie, PRPSC, will give you something in first place. I don't know if there's necessarily a final word on that. I think there are some instances where you can make an argument that there was a cross of a species, and I think the best example for that will be the variant Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease is a neurological condition that presents with dementia. Patients can have some seizure activity, some specific changes in the EEG as well, and it's uniformly fatal. And we know that can present in families, but also we saw some cases in the UK and some other places in Europe in the mid-1980s and 1990s. And if you read about it, you're gonna figure out that the most likely cause of that is because of contamination of produce from mad cow disease. And if you go back even further, that you're gonna realize that the reason that that happened is because of the oil crisis in the 1970s. By the time that happens, I think I was only 3 years old, so maybe I'm just quoting Wikipedia here. But in 1973, there was an oil embargo from the OPEC producing countries, right? And trying to burn that produce from animals in the UK got very expensive, so there was a change in the way they were processing these carcasses and all these materials. So somehow that allowed that produce that came from probably scrapie from cow, from other animals, used to feed cows, and then you got dinged with variant Creutzfeldt-Jakob disease, which is very uncommon to begin with. And that problem went away as soon as they realized the problem. So whether that can be translated to other prion disease, not so sure about that. And we know about the chronic fatigue syndrome and all those things. I don't know. It was just one of those one things only. So I guess the word is still out there, but I think it's somewhat unlikely. I think there's just a bunch of things that have to be aligned together really well for having that jump into from one species to another. And that happens to other infections as well. Any other questions? Don't be shy. Yes, sir.
Talk about any new antibiotics that are coming up in the horizon, what they're used for.
So I guess the last thing I heard was this stuff in Nature a couple of days ago. I haven't learned the name yet. I think apparently it's a new antibiotic that has a very specific way of working against bacteria. It sounds like it has a pretty broad spectrum activity. I think before we see that being a product that you can order in the hospital, I think it's going to be a while, because that's kind of the pace that a pharmaceutical industry has for antibiotics. But there's definitely a problem with new antibiotics. There's a couple of things coming in the market. Most of them are actually more for gram-positive organisms than gram-negative organisms. So you're going to have things like oritavancin, telavancin, dalbavancin, that are already here basically. Some other new agents for gram-negatives like ceftaroline, and I think there's going to be another new combination similar to piptazo, to piperacillin tazobactam. But in all honesty, those medications are not necessarily new, because they're just kind of modifications of molecular entities that we have. And that has been always the big discussion, that in theory, yes, we have these new compounds, but they're not really new medications. And trying to come up with a new antibiotics is extremely hard, and it's extremely expensive. If you start a project to get an antibiotic, if you're lucky to have a compound, it might be 5-10 years before you have a compound that you can really use in a clinical setting. And that's just for bacteria. I'm sure there's a lot of other problems for other things, treatments for cytomegalovirus, for Ebola, as you can see, with all those things that happened last year, and for fungal infections. So there's definitely a lot of need in different areas. And I think that the problem is that, we treat these infections, and I guess it's one of the few things in medicine that maybe you can say that you have really cured somebody in some instances. So for a pharmaceutical company, maybe not the most, not the best proposal from an economical standpoint. It's kind of better to have a person taking Lipitor the rest of their lives, nice income right there, instead of taking an antibiotic for 14 days and up you go. But the government and some other entities recognize the need for new antibiotics, and so we might see more and more products coming to the market, and I think it's because of the advocacy that Infectious Diseases Society of America and some other entities have pledged to maybe promote the development of new compounds and try to pass some legislation to encourage pharmaceutical companies to work on this.
Due to the difficulty to produce new antibiotics, do you see there being more vaccines being developed to try to prevent things instead of?
Yes and no. I think there's always a need for vaccines. I think it's definitely one of the most cost-effective measures in public health. But vaccines, unfortunately, it's kind of a touchy subject for different reasons. First thing, for example, you give a vaccine, and something happens. You can report that as a side effect, even though that could be completely unrelated to the vaccine. And behind that, there is a complete background on how to protect the pharmaceutical companies from lawsuits, having this fund for vaccine damages, even though that it's not that hard to get compensation for. And vaccines are probably one of the most tried medications, if you want to call it that way, in the market. So there's a lot of drawbacks for companies to get into that. I think most of them can be driven by circumstance, like the Ebola outbreak, for example. So you have GlaxoSmithKline and Merck working on 2 vaccine candidates, but I think it's because there is a need right now. In the other hand, maybe 10, 15 years ago, there was the development of a vaccine for Lyme disease, and nobody used it. And it worked, and some side effects, but no one was using it, and that's basically back on the shelf. So unfortunately, I think there's a lot of reaction instead of pro-action in the development of vaccines. There's definitely some room for some other conditions to be susceptible to be managed with vaccines. But vaccines are also pretty hard to come to the market, and the requirements for getting them to the market are very strict. They require a lot of clinical trials before a vaccine is even a candidate, and probably the chances of having a good vaccine are probably less than developing a pharmaceutical agent. So very difficult situation. And again, you wonder whether maybe some legislative action might be more useful in promoting that. And we haven't even touched the subject of vaccine denialism right there. So, lots of things to think about. Any other questions?
Excellent, thank you
So much.
Thanks so much.